Now we're going to move on to high-risk antepartum. Complications early in pregnancy that can arise can be abortions, molar pregnancy, ectopic pregnancy, incompetent cervix, placental abnormalities, hyperemesis, and hypertensive disorders of pregnancy. Under the abortions category, or miscarriage, this can be a spontaneous or an elective termination of pregnancy before the age of viability, which we've already established is 20 weeks gestation. This can often be due to severe malformation of the fetus when we're talking about spontaneous miscarriages. There are different types of abortions. There are threatened, inevitable, incomplete, complete, and missed. A threatened abortion is when the woman experiences cramping, backache, maybe some slight spotting, but the cervix remains closed and she has not passed any fetal tissue yet. The inevitable miscarriage or abortion is when there's an increase in bleeding noted, there's cramping, and the cervix starts to dilate. An incomplete abortion is when there's bleeding and cramping and now there's some passage of fetal tissue. A complete abortion is the passage of all products of conception. The cervix will then close and the bleeding will stop. A missed abortion is when the fetus dies in utero but is not expelled. And so then we need to then remove the fetus with a procedure called a D&C, which is dilatation and curettage. If somebody has 3 or more consecutive spontaneous abortions, we call that a habitual aborter. If they have to have a termination of pregnancy due to an incompatibility with life or to save the mother's life, we call that a therapeutic abortion. And not every hospital does a therapeutic abortion. A lot of Catholic hospitals will not do these. And an elective is a maternal choice to terminate the pregnancy for whatever reason she chooses. When we talk about a molar pregnancy, this is a significant thing that can happen where the development of abnormal chorionic villi of the placenta takes place. So this has caused an overgrowth of sac-like vesicles that kind of resemble grapes, and you can see that picture up in the right corner, and it's seen in the uterus on ultrasound. There's often no or some partially formed fetus that's present. So a partial molar pregnancy is when there's an abnormal placenta but some fetal development. A complete molar pregnancy is when there's an abnormal placenta and no fetus or fetal development. This is also referred to sometimes as a hydatiform mole. We can use methotrexate to treat this once only if this overgrowth of cells leads into cancer, which this is one of the risk factors of having a molar pregnancy or hydatiform, is that because there's an overgrowth of cells, it's similar to how cancer occurs where there's an overgrowth of cells, and this could put you at risk for cancer for at least a year after you have a molar pregnancy. So it is recommended that once you have a molar pregnancy that you do not get pregnant for at least a year. And so if it does turn into a cancer, they can use the methotrexate to help with treating that. So pregnancy should be avoided, like I said, after a year, and you have to ensure that the HCG levels of pregnancy return to normal. And sometimes the HCG levels are so high during a molar pregnancy that it takes about a year for them to return to normal levels. Because if any vesicles remain, this is where it can turn into cancer. And that's when we use the methotrexate. Another type that can occur is something called an ectopic pregnancy. This is when the zygote does not pass fully through the fallopian tube into the uterus, and it starts to implant and grow right in the fallopian tube. And there's a picture of that up in the right corner. The tube is unable to support growth and the development of the zygote. Obviously, there's not any room for a baby to grow there. So the zygote will either die or it will be reabsorbed by the body. But as the fetus is trying to grow in that constricted area, it can cause the fallopian tube to burst, which causes a surgical emergency. Symptoms of an ectopic pregnancy can be low abdominal pain, amenorrhea or light amount of vaginal bleeding or spotting, and that pain often radiates to the shoulder and down the body. So we call that referred pain. So oftentimes a pain that a patient may feel may only be in their shoulder, and this can be from the fallopian tube starting to burst. If it does rupture, it does cause severe pain and obviously bleeding. So a patient is at risk for hypovolemic shock from that severe blood loss, but the vaginal bleeding might be minimal on observation, as the bleeding is occurring in the lower abdomen and not being visually seen, like through the vagina. Treatments for the ectopic pregnancy could be to monitor the patient for hypovolemic shock, verify the pregnancy by either a blood serum or a urine HCG level, doing a pelvic ultrasound, or a laparoscopic exam. You may need to give the mother RhoGAM if she is Rh negative, because this is one of those instances where her negative blood type might have come in contact with a positive fetus, because even in that molar pregnancy, there's a blood type attached to it. Methotrexate in this case is given to terminate the pregnancy and allow the pregnancy to be reabsorbed by the body. There's a correction if surgical is needed if a tube had ruptured. And they try to save the tube, but that's not always possible. Another complication can be an incompetent cervix. This is a mechanical defect in the cervix that results in cervical dilatation somewhere around the second trimester. A woman may feel increased pelvic pressure, and upon examination, the practitioner would notice the cervix is starting to shorten or thin, or it may even start to dilate. The treatment is called a cerclage. And as you can see in that bottom right picture, it looks like a little stitch, or what sometimes I refer to as a button, where we would sew that into the cervix, trying to close the cervix and keep it from dilating or opening anymore. So this is often done if a person has a history of incompetent cervix, a miscarriage from a previous pregnancy due to this. They will oftentimes give her a cerclage to be preventative so that this pregnancy can be carried to term, ideally. There are some cases where we don't know that she has a history of this and she can start to dilate, and we can do an emergency cerclage. And these work pretty well, but there are cases where the cerclage is in and that's still not stopping the cervix from dilating. So the cervix will still try to dilate, and what will happen is it'll start to tear at the cervix because the suture will remain intact, but the tissues of the cervix will start to tear. In that case, obviously we can't allow that to happen. We'll have to cut the cerclage out, allow her to dilate, and eventually lose the pregnancy. Another complication is the placenta previa. This is when the placenta attaches to the lower uterine segment of the uterus, near or over the opening of the internal cervical os. So placentas should ideally attach anteriorly or up on top by the fundus. So we talked about the fundus as the top of the uterus. That is about where the placenta normally and should attach. But in a previa, the placenta attaches lower than it should, and it can cause issues with bleeding, and it can also cover the opening of the cervix, obviously allowing difficulty or not allowing a vaginal delivery because the placenta is in the way. The occurrence of this could be 1 in about every 200 to 300 pregnancies, so it's not uncommon. You're at higher risk if you are AMA, which is advanced maternal age, which is over the age of 35. If you're a multipara, which we know this means multiple deliveries. If you've had a previous C-section, or if you have a history of a suction curettage. That's what we talked about with that dilatation and curettage, where we dilate the cervix and we remove the products of conception. So if you have a history of that, that could put you at risk. It's likely to reoccur, and the prevalence in African Americans and Asians is higher among all races. And the reason why some of these things make you a risk factor, like the multiple paras, like the C-section, or the history of suction curettage, is because of scar tissue. Placentas have a difficult time implanting over scar tissue. So when you're pregnant, each and every time, the placenta has to find an ideal place to implant, and it won't normally choose to implant over scar tissue. So if you have multiple pregnancies, it needs to find new areas to implant. And if you've had a C-section or a suction curettage, that can leave scarring as well, and then make it difficult for the placenta to implant where it should, and then it ends up implanting lower. So there are different types of placental previa. There's the complete or total previa. There's the partial previa, or what they can call marginal previa. Those words are interchangeable. And then there's the low-lying placenta. So notice in the normal placenta, it's this part right here, this red part right there. It should implant kind of up and away from the cervix. In a marginal or partial previa, it's right on the margin of the cervix, so it's lying really low there. And then the complete previa, it's completely covering the cervical opening. A low-lying placenta would be similar to the margin, but it wouldn't touch the margin of the cervix. It would be lower than normal, but not quite near the cervix. Another abnormality that can happen with the placenta is an accreta. So a placenta accreta is an abnormally adherent placenta, which can cause hemorrhage in the intrapartum or the postpartum period if the placenta does not deliver cleanly at all. So normally, when the placenta attaches, after delivery, the body will send a message to the brain that it no longer needs the placenta. When that happens, the placenta will start to naturally, on its own, detach from the uterus, and then it can be delivered through the vagina, and that usually happens within minutes after delivery, up to about 30 minutes, but it will happen naturally. Well, what happens in an accreta or an increta or percreta, which you're seeing here, is that the placenta attaches too deep, deeper than it normally should. And when that occurs, it cannot unattach easily, and it makes it difficult for it to not cleanly be delivered and come out of the uterus. If a placenta does not detach, the mother will continue to bleed into the uterus, and then that's what's leading to the hemorrhage, the postpartum hemorrhage. So an accreta is when it abnormally adheres to the uterus. The increta is when the placenta now penetrates through the uterine muscle, and the placenta percreta is when it now penetrates all the way through the uterus, and now it starts to attach to the abdomen. In the increta and percreta, it is likely that that placenta is not going to come out, and the mother would need to have a hysterectomy. In the accreta, there are things we can do to try to remove it. The practitioner can try to manually detach it with an instrument or with their hands, and we can either bring them in surgically and try to surgically detach it. However, in not every case can it be detached that way, and that mother still may require a hysterectomy because we cannot leave that placenta behind or she would bleed to death. So we either have to try to remove it or we have to remove the whole uterus. So these are the different types of accretas. This is a normal placental attachment. You can see the accreta, it's a little deeper. The increta, even deeper so through the entire uterus. And now the percreta through the uterus, and this is where it would start to attach to the abdomen. Another complication is the placental abruption, or we call this abruption placentae. Interchangeable words. This is a premature separation of a normally implanted placenta. So as I just said, the placenta will automatically detach once the baby is delivered. But in some cases, the placenta will start to separate prematurely, meaning when you still need it and the mom is still pregnant. This can oftentimes be caused by abdominal trauma, to which the placenta starts to tear away. It could be caused by increased blood pressure in those hypertensive disorders of pregnancy like preeclampsia. It could also be caused by some other issues here. What you'll see on an ultrasound is a hematoma, which shows you that there's a collection of blood from where that placenta started to detach. The symptoms can be vaginal bleeding, abdominal pain, back pain, or uterine tenderness. And if you have mom on an external fetal monitor looking at her contractions and the fetal heart rate, you'll notice that the uterine contractions are consistently constant with no resting tone in between, meaning that the uterus is in a hypertonic state. So there are different grades of placental abruption, meaning the amount to which they are actually separating. So a mild grade placental abruption is when there's less than 15% of the placenta that's starting to separate. A moderate or a grade 2 would be up to 50% or half of the placenta starts to separate. And grade 3 or severe would be over 50% of the placenta separates, or the complete placenta separates. So obviously it's more severe the more that the placenta separates, because for whatever part is separated from the uterus is the part of oxygen and blood flow that the baby is no longer receiving. So if the baby's only getting half of the blood flow and the oxygen that it needs, if half the placenta is not attached. You can notice with the mild grade placenta abruption, you may have some concealed bleeding. You may not know that the hemorrhaging is going on because it's concealed into that one spot, which is where we see that hematoma. However, when it starts to separate 50% or more, there is usually some visual bleeding going on through the vagina. There are predisposing factors that can cause the placental abruption. Those could be if you have a prior history of it, if you have hypertension, if you use cocaine, if you're a smoker, if you have poor nutrition, or again, if there was any kind of abdominal trauma. That could be a fall to the abdomen, abuse like a kick or a punch to the abdomen. It could even be like a car accident where there was trauma or an abrupt smashing against the abdomen. We will, in order to care for someone who has a placental abruption, we need to monitor them for hemorrhagic shock. We monitor them for DIC. And if you guys remember from your 1600 or 1601 class, that is disseminated intravascular coagulation, which can occur when the body goes into a trauma-like state where it tries to use up all its platelets to help all the extra bleeding that's going on. So the platelets kind of go into overdrive. And what happens is you use so many platelets up that you now deplete all your platelet reserve. And now you don't have any platelets to clot off the blood. And so you go into a DIC state, which means that you're unable to clot any of your blood, and then your blood starts to pour out of every orifice of the body. And that can be the vagina, the rectum, the mouth, the eyes, the nose. So this is an obviously very serious complication of a placental abruption and could lead to both death of the fetus as well as the mother. The treatment in a placental abruption, and again, depending on the degree, if it's a mild abruption, a mother still may be able to deliver vaginally as we watch her for signs of hemorrhagic shock. We watch that the baby's doing well. But in a more severe case, like a moderate or a severe abruption, she would need an emergency C-section. We would need to replace the blood products that she lost, and we would need to do frequent monitoring of the mother and the fetus until that baby is delivered. Nursing care for the patient who's having excessive bleeding. We want to obviously document the blood loss, closely monitor her vital signs and her eyes and nose, and look for signs and symptoms of shock. No manual vaginal checks. We want to observe for pain, uterine rigidity, or tenderness. We want to verify that orders are there for blood typing, and we want to cross-match that blood in case she needs to replace those blood products. We prepare her for surgery. We monitor the fetal heart rate and contractions. We monitor her lab results, we administer oxygen as needed, and we prepare for the baby to require some sort of resuscitation. Another complication that can occur is a cord prolapse. This is when the umbilical cord slips down and gets compressed between the fetus, or whatever the presenting part is of the fetus, and the cervix. This can usually occur after the rupture of membranes when a gush of fluid pushes the cord through the cervix. It's often associated when the fetus is at a high station, which I understand you haven't had labor yet, so it doesn't quite make sense to you, but it's where they're sitting in that birth canal. A small fetus, breech presentations where their head is not blocking the cervix, but their feet or their butt is, and so there's more room. When they're in a transverse lie, which means that they lie side to side instead of up and down, or if they have polyhydramnios, which we know is too much fluid. Any of those can cause a gush of fluid to propel that cord past the fetus and through the cervix. If that happens, the head will then compress the cord against the cervix and cut off its own oxygenation. So obviously that baby would require an emergency C-section, as well as lifting the head up off of the cervix and getting that pressure off and allowing the practitioner to get mom to the OR for a cesarean section delivery. All right, so we're going to move on to another complication, hyperemesis gravidarum. This is excessive nausea and vomiting that lasts well after the first trimester, when the normal nausea and vomiting of morning sickness, it kind of surpasses that. This is uncontrollable and basically intolerable. It can lead to dehydration, electrolyte and acid-base imbalances, starvation, ketosis, as well as weight loss. You often see on the mom dry mucous membranes, poor skin turgor, malaise, hypotension, tachycardia, concentrated urine, and an increased hematocrit. This often requires mom to get more than just dietary changes. She'll require some sort of antiemetic, IV fluids at times, sometimes even a pump that gives her constant pumps of Zofran or Phenergan. And a lot of these moms end up being hospitalized because it is just such consistent vomiting that they're trying to maintain the pregnancy without, hurting the mom too badly. Treatment again, IV replacement, antiemetic drugs, TPN if needed. We want to again educate her on eating properly, but that's not going to be the be-all end-all cure. She's going to probably require a little bit more. Another complication of pregnancy can be gestational hypertension. So gestational hypertension is different than just hypertension because it's high blood pressure that occurs because of the pregnancy. And it usually will develop after 20 weeks. Now, a mother can have gestational hypertension, and then when she's not pregnant anymore, her blood pressure returned to normal. However, she could have gestational hypertension that can lead her to a hypertensive patient even after she delivers. And she can also have gestational hypertension that can turn into a more severe variant of hypertension. And that's when we look into preeclampsia and eclampsia. So preeclampsia is when her blood pressure now exceeds 140/90. She's spilling protein in her urine. She has a sudden weight gain due to fluid retention, normally seen in the face, the hands, the lower feet, and now it's pitting edema. And preeclampsia means pre-seizure, meaning that this variant, this problem she has, puts her at a higher risk for seizing. Eclampsia is when convulsions occur on top of this chronic hypertension she has. The main characteristic of preeclampsia is that there's a vasospasm which will impede the blood flow to both mother's organs as well as her placenta. And obviously if blood flow is impeded to the placenta, it's also impeded to the baby. So again, pre-seizure. We're going to look at a protein creatinine ratio. This is a quantitative assessment of the amount of protein urea that's from a random urinalysis sample that will tell us how severe this preeclampsia is in mom. Symptoms that she may experience with preeclampsia is severe frontal lobe headache, almost an intolerable headache like a migraine, hyperactive deep tendon reflexes, visual disturbances like seeing double or seeing spots, having decreased urine output less than 30 milliliters an hour, having pulmonary edema, which you can hear when you're listening with your stethoscope, the swelling, where we named before the feet, the face, the hands, and epigastric pain and nausea due to the liver being edematous. And you would see that in labs as well with an increase in liver enzymes. Again, when eclampsia occurs, that means the woman has all those symptoms that I just named, plus she has now seized. This can result in cerebral hemorrhage, abruptio placentae, fetal compromise, and the death of the mother and or the baby. And the effects on the fetus can be that they're getting decreased oxygenation. They can have meconium stool due to the stress, which puts them at risk for meconium aspiration once they're born. They can have growth retardation or death. When we diagnose preeclampsia, we're looking for increased blood pressures. We're looking for protein in the urine due to a urine analysis. We're looking at labs, specifically elevated liver enzymes, and we're looking for increased uric acid level. And we get concerned when it's above 6. Additional assessments would include doing deep tendon reflexes to look for that hyperreflexivity, clonus, if she has any beats of clonus. We're looking at her platelet count because in this case, platelets can start to go down, and we're concerned again about DIC, so we're looking at that. And we're looking at her creatinine clearance. If a mother is diagnosed with preeclampsia, here are the treatments that we're looking at. So the goal is to control hypertension and prevent seizures. That's the main goal when you're treating preeclampsia. So what medication do we use for this? We use magnesium sulfate. Magnesium sulfate is a neuromuscular depressant that blocks acetylcholine at the neuromuscular junctions. This is classified as an anticonvulsant. So this is important to remember. Magnesium sulfate is not an antihypertensive. It's not meant to decrease the blood pressure. However, it can do that as a side effect, but it's not its main goal of this medication. This medication is classified as an anticonvulsant. It is a smooth muscle relaxer, and we use this to prevent seizures. Then on top of that, we can use antihypertensives like aprepiline or labetalol. Technically, delivery is the only cure, meaning that preeclampsia is a condition that occurs only during pregnancy. So when not pregnant, the condition goes away. So if the condition is severe enough, we will deliver the infant to help to save mom, even if it means delivering the baby early. Some nursing interventions when you have a mom that is using the magnesium sulfate, you want to make sure that we're doing magnesium that's infused intravenously IV. There's normally a loading dose of 4 grams, and we give that over about a 20 to 30 minute period. And then we reduce that to a maintenance dose of 2 grams an hour, usually in about 100 milliliters. Labs are drawn every 4 to 6 hours after we initiate this treatment, and then either again at 12 or 24 hours. We do a complete blood count, we do a magnesium count level, we do a bilirubin check, we do liver enzymes like AST and ALT, we look at platelets, we look at BUN and creatinine and uric acid. A normal magnesium level is between 6 and 8 milligrams. We need to see that in order for it to be therapeutic. We want to monitor for signs of mag toxicity. Now understand that in order to get magnesium sulfate to be therapeutic, it has to hover on the high level ends. Well, when you're on the high levels of magnesium, you are at risk for magnesium toxicity. So at the same time we're treating her with this medication, we have to continue to observe that we're not overdosing it or getting her to the point where her body can't excrete it and she's becoming mag toxic. So we want to make sure when she is on magnesium sulfate that we're doing frequent vital signs. It's every 15 minutes for the first 2 hours. And then if she's stable, we'll move it to, after 2 hours, we'll move it to every 30 minutes and then eventually every hour. We do continuous pulse oximetry to look for any kind of respiratory depression. This medication, because it's a smooth muscle relaxer, can depress respirations. We can insert a Foley or at least measure her urine every hour to make sure she has an adequate urinary output. We want at least 30 milliliters an hour. We want to assess deep tendon reflexes and clonus every hour. Now remember when I said if they are preeclamptic, they can have hyperactive deep tendon reflexes? Well, if they are magnesium toxic, they can have absent or very little deep tendon reflexes. So when we are testing the reflexes, we really want them to be normal, +2. We don't want them to be hyperactive because we know she's at a high risk for seizing, but we don't want them to be low or absent because she's at high risk for becoming mag toxic. So you need it to be right there in that middle zone. We want to assess her level of consciousness every hour. We want to assess for those headaches or visual disturbances that she can have, and we want to auscultate the lungs frequently because we're looking for pulmonary edema. Signs that the mother may be experiencing magnesium toxicity are below. If she is exhibiting any of these signs, we want to stop the magnesium immediately, and we want to administer calcium gluconate, which is the antidote for magnesium sulfate. And it's usually 1 to 3 grams given over 5 minutes IV. And whenever someone's getting magnesium sulfate in the hospital, calcium gluconate is usually kept in the room in case of these emergencies. If we notice absent deep tendon reflexes, a respiratory depression of less than 14 breaths a minute, if the urinary output falls below 30 milliliters an hour, if she's starting to exhibit slurred speech or complaining of blurred vision, severe muscle weakness or chest pain, this is when you want to immediately stop the magnesium because she's heading toward toxicity. Another condition that can occur, and it's along the hypertensive disorders of pregnancy realm, is HELP syndrome. And HELP is an acronym for hemolysis of red blood cells, elevated liver enzymes, and low platelets. This is a particularly dangerous variant of preeclampsia. This puts you at risk for DIC, disseminated intravascular coagulation. So we know that the platelets will drop, the clotting proteins in the blood are now consumed, profuse bleeding can occur, we must deliver the baby immediately, and we have to focus on stabilizing mom and closely monitoring them. Often moms who go into HELP syndrome and then eventually DIC often end up in the ICU and their baby's in the NICU as well. Another complication of pregnancy can be gestational diabetes. Moms can have pre-gestational diabetes or gestational diabetes. So gestational diabetes is glucose intolerance with the onset happening during pregnancy. It will usually return to normal, or she will no longer be diabetic by the 6 weeks postpartum. However, there are some instances where women can continue to be diabetic even after they deliver. So the reason why women develop gestational diabetes is that pregnancy affects the metabolism to increase glucose available to the growing fetus. So we're trying to make more glucose available to the baby. Estrogen, progesterone, and prolactin increase the speed of insulin breakdown. And this then increases the cell resistance to insulin. Most women can respond by just secreting more insulin. However, if they cannot meet that demand, this causes them to become gestationally diabetic. The risk factors for gestational diabetes are maternal obesity, over 200 pounds, a large infant, over 9 pounds, we call that macrosomia, maternal age greater than 25 years old, history of a gestational diabetes pregnancy and past pregnancies, or a family history of diabetes mellitus. We will test for this by doing a screening. It's called a glucose tolerance test, and it's done between 24 and 28 weeks, where the mom will drink this very sugary substance and then have her blood drawn, and it will show how much of that glucose still remains or if she had enough insulin to counteract that. Blood levels over 140 results in you having to do an additional 3-hour test. If that 3-hour test is not passed, then you are considered a gestational diabetic. Now, treatments if you are diagnosed with this. We will monitor blood sugar levels. We'll make sure our patients are eating 3 balanced meals a day with 2 snacks throughout. So it's mostly diet controlled. Most of these moms can get away with diet control. Insulin can probably be ordered because many oral hypoglycemics don't cross the placenta, so they don't help us when mom is pregnant. Glyburide is one of the only safe oral hypoglycemics that they may use. Care during labor may have to be an infusion with dextrose, as well as blood sugar checks hourly, and then an insulin drip may often be needed as well. Babies will need to feed immediately after birth because they will be born hypoglycemic because of the insulin glucose imbalance. And then down here, this is an obviously macrosomic baby. So, this is a fairly large baby, but babies born to gestational diabetics tend to be on the larger ends, 8, 9, 10, 11 pounds. Another complication of pregnancy can be the Rh incompatibility, which we talked about in previous slides. So again, the Rh negative mom and the Rh positive fetus. The father of the baby must be Rh positive for this to occur. The problem is for the fetus. It does not harm the mother, but it can harm the fetus. So we note Rh negative is a recessive trait, meaning that it's rare. That's why Rh positive is most likely what the fetus will be, especially if the father is Rh positive. The mixing of the fetal Rh positive blood into the Rh negative mother's circulation, again, will cause her body to respond by making those antibodies and to destroy the Rh positive erythrocytes because they recognize them as a foreign substance. With subsequent pregnancies, the woman's antibodies against the Rh positive blood will cross the placenta and destroy the fetal Rh positive erythrocytes before the infant is even born. That's again where the RhoGAM comes in place. So the medication we talked about earlier that's used to prevent this from happening, it prevents the mom from forming these antibodies. Again, we give it at about 28 weeks routinely to the Rh negative moms in preparation for her delivery and the blood that we know will mix. Also, it's given after maternal fetal blood can potentially mix. So this can not only be given at 28 weeks, but we can give it whenever we're worried or that we know blood has mixed during a chorionic villi sampling test, an abortion, an amniocentesis, uterine bleeding, ectopic pregnancy, implantation bleeding, miscarriage, trauma, or delivery. And then again, given within 72 hours after delivery, if the baby is then found to be Rh positive, it's protection for the next pregnancy, and Rh antigens are destroyed. Does not make permanent antibodies. If the Rh antibodies are formed in the maternal blood, it will cross the placental barrier and destroy those fetal red blood cells, which is called hemolysis. And the destruction of these red blood cells will increase fetal bilirubin levels, which we talked about in the earlier normal newborn slides. So rapid production of these erythroblasts, or these immature red blood cells, cannot carry oxygen effectively. And then a condition occurs called erythroblastosis fetalis. And this is when the fetus becomes anemic, and there's generalized edema, and it leads to hydrops fetalis, which is a fetal congestive heart failure, and potentially can kill the fetus. And again, another picture for those who are visual learners of the Rh negative blood cell, the antibody, and how it's trying to attach to the Rh positive blood cell of the fetus. When we talk about blood incompatibilities, we also talked earlier about ABO incompatibility, and that again is when the mother is the O blood type and the baby is the AB or the AB. In this case, if the baby is AB or AB blood type, these blood types contain an antigen that's not found in the O blood type. So the IgG antibodies from mom that the mom creates will cross the placenta barrier and hemolyze the fetal red blood cells. This will lead to a neonatal uncomplicated hyperbilirubemia or a more severe anemia. And again, we talked earlier about the Coombs test, the two blood tests that we can do, the check for antibodies that attack the red blood cells, the direct Coombs test and the indirect Coombs test. Again, that direct Coombs test is done directly to the newborn, and it's a sample of red blood cells from the body, and it detects antibodies that are already attached to their red blood cells. An indirect Coombs test is one we do on mom, where it detects unattached antibodies that are present in mom's bloodstream and could bind to certain red blood cells, leading to problems once the blood mixes. Another complication, although it's not technically a complication, it's a blessing if you look at it. However, it is a complication when we talk about safety and health of the pregnancy, is multiple gestation. So you can have different types of twins. Those are monozygotic twins, which is one zygote that that divides into two identical twins. Or you can have a dizygotic twin, results from two separate fertilized eggs. You can also have different placental types during the multiple gestation. You can have a monochorionic, which means you have one chorion or one placenta, or you can have a dichorionic, which means you have two chorions. So you can either have two babies sharing one placenta or each baby having their own placenta. So remember, chorion means placenta, amnion means amniotic sac. So when we talk about the different types of twins, we're referring to di-di, mono-mono, or mono-di. So di-di twins, which is what we refer to as fraternal twins, means there's two placentas and two amniotic sacs. That's the safest type of twins to have. They each have their own source of oxygen and blood flow. They each have their own home, if you will, with their amniotic sac. They're not sharing anything but the uterus. In mono-mono twins, this is the riskiest type of pregnancy to have with twins. This means that the twins are not only sharing one placenta, but they're sharing one amniotic sac. Oftentimes, moms who have mono-mono twins require bed rest for a majority of the pregnancy because they're at such a high risk of losing one or both twins because of this. And then another type is the mono-di twins, where they have one placenta but two amniotic sacs. And this can occur often with identical twins. So these are just pictures for those visual learners. Monoamniotic, monochorionic, so those are those mono-mono. Again, remember that dangerous type, they're sharing one placenta. They have two umbilical cords, but it's attached to one placenta, and they're in the same sac. And then you have the di-di. This one has its own placenta. This one has its own placenta, and they each have their own amniotic sac. And then you have down here the di-mono, where they each have their own sac, but they're sharing a placenta. And this is when they're actually physically separated. So multiples, you have increased risk for what's called IUGR, or intrauterine growth restriction, meaning that when two are sharing the space of one, sharing the uterus, sometimes sharing the placenta, it can cause their growth to be restricted. It can also cause something called twin-to-twin transfusion syndrome, or what we call discordant twins, where the placenta is feeding one baby more than the other baby. So notice this baby's getting bigger and bigger, and this baby's growth is being restricted. This is called discordant twins. This is an example here in this picture. These are twins. This baby got all the food, this baby did not. So that's called twin-to-twin transfusion. When a mom is pregnant with twins, they are continually monitored, often by ultrasound, to look for this. If there is a significant difference in the growth between two twins, they will often take the twins early to save the little one. So another visual picture of the differences of what happens in the gestation, fertilization, and pregnancy of the identical twins versus the fraternal twins. So different other symptoms that can become a problem in high-risk antepartum when we're talking about things that can go awry is the exacerbation of the body's symptoms with pregnancy. So earlier in the antepartum slide, we talked about how every system in the body is being affected by pregnancy. But some of those effects can cause dangerous conditions to the mom. So we're going to look at it in this case. So in the cardiac body system, pregnancy can put a strain on a woman's heart, specifically with a previous heart condition, and it can increase her cardiac output in pregnancy and delivery, and some moms just cannot accommodate for that. Pulmonary-wise, it can put a big strain on those who are asthmatic or have an increased risk for respiratory alkalosis. In the urinary system, it puts an increased risk to mom to get frequent urinary tract infections, kidney infections, as well as kidney stones because of the increased glomerular filtration rate and the amount of work it has to do. In the gastrointestinal system, it can cause mom to have cholelithiasis, which is the gallstones, or hemorrhoids. And it can put mom in the vascular system at increased risk for thrombosis. So increased risk for DVTs due to that extra blood volume, the fact that they have more clotting factors. And this could be significant for those who have obesity, who have surgery. Surgery in general puts you at risk for thrombosis, but now a C-section would fall under that category. Those who are stasis or on bed rest, which can sometimes happen if you are on bed rest, say due to the mono twins or preterm labor, so long periods of bed rest. But even if in labor, you can be in the bed for long hours due to having an epidural and you can't get up and move around, and a long labor. So you could technically be in bed rest without moving around for days, and this could put you at risk. As well as smoking is another risk factor. When we talk about some risk, we talk about infections, and there is a group of infections that we refer to as torch infections, and these are infections that can have devastating effects on the fetus or the newborn. And torch, again, is another acronym. It stands for toxoplasmosis, other, which I'll talk about, rubella, cytomegalovirus, and herpes. So, toxoplasmosis is a non-viral, it's a parasite that's acquired from cat feces and raw meat. So for anyone who's ever been pregnant before, one of the first questions a practitioner will ask is, do you have a cat and do you change the litter box? If you do have a cat, they will tell you that you cannot change your litter box during the pregnancy due to the fact that you could acquire this parasite from the cat feces, causing this toxoplasmosis, which can cross the placental barrier. So clinical manifestations in the mom are going to be mild, but in the baby, it'll be significant. It can cause a spontaneous abortion, low birth weight, enlarged liver and spleen of the fetus, jaundice, anemia, inflammation of the eye structures, or neurological damage. The hepatitis B is the main one that falls under other. This is transmitted per blood, saliva, vaginal secretions, semen, breast milk, and these all can cross the placenta. All women are screened for hepatitis B. Infants will then get a hepatitis B immunoglobulin or a Hep B vaccine as routine if mom tests negative. And all newborns are routinely going to get this vaccine in a series. And they'll get this within the first 2 weeks of life, usually done right there in the postpartum period. And then again, with their well visits in the next month or so. They'll get the remaining 2. Another one that falls under other is HIV. 20 to 40% of chance of infecting the baby if mom is positive for HIV. The infant will be at HIV positive at birth if this occurs. breastfeeding is contraindicated with moms who are HIV positive, and the mother and the baby are both given zidovudine, which is an antiviral. Rubella is another infection that can have detrimental effects on the baby. So rubella or German measles, in the mother, it can cause a rash or a fever, and they could be fairly mild. However, in the fetus, it disrupts the normal formation of major organ systems and causes major anomalies. It could equate to microcephaly or small head of the fetus, mental challenges, cataracts, deafness, cardiac defects, growth retardation, and hepatitis. So this is preventable if a woman is vaccinated. So remember, though, that the immunization is a live vaccine. So if she is not immune, or if she has a weak immunity, she needs to really be careful to avoid anybody who may have German measles, because she cannot receive that vaccine booster until after she delivers. So at least 3 months before pregnancy, it's recommended that she either have it tested to see if she's immune, or if she's not, to get the vaccine. So remember, that would fall under that perinatal or pre-genetic counseling. We're going to go ahead and counsel even before you get pregnant to make sure kind of like all your ducks are in a row, if you could. And then again, she can get it in that postpartum period, but never when she is pregnant. Another infection is called cytomegalovirus virus. This is a member of the herpes virus family. It is sexually transmitted, and many times mom can be asymptomatic. However, the baby will have the following: mental retardation, seizures, blindness, deafness, dental abnormalities, and petechia. The treatment would be to isolate the baby. It can secrete this virus through the saliva and urine for years. So for the mother, there is only symptomatic treatments if she is symptomatic. Another infection we're going to just talk about is herpes. If mom is herpes positive with active herpes lesions, then she requires a C-section delivery. And we do this to prevent contact with genital vesicles, which are active or erupted, to come in contact with the fetus or the baby. She could deliver vaginally if the lesions are not active. So we want to make sure we do standard hand washing precautions, that mom and baby do not need to be isolated if direct contact with lesions is avoided. And a newborn bath immediately following delivery is required. Some other miscellaneous infections can be chlamydia, gonorrhea, trichomonas, all that can be treated with antibiotics. And remember, we don't want to just treat the mom, but we want to treat the partner as well, so they're not passing it back and forth to one another. We've talked about group B streptococcus before, but just to review, it's the asymptomatic maternal normal flora bacteria that can be dangerous to the baby once the baby passes through it, or there's rupture of membranes and it's now in the amniotic fluid. The rectum and vagina are swabbed at 35 to 37 weeks, and if positive, mom will need to be treated prior to a vaginal delivery. She does not need to be treated if she has not ruptured her membranes or if she is a scheduled cesarean section. So the treatment is IV penicillin every 4 hours until delivery, and she must have at least 2 doses in her system to be considered treated. Another infection that can occur is something called chorioamnionitis. This is a bacteria infection that infects the chorion and the amnion, which are the membranes that surround the fetus, as well as the amniotic fluid. It's most common with those women who have prolonged rupture of membranes, usually anything over 24 hours, but can even start to occur between 12 and 24 hours of having your water broken. But it can also occur even if the membranes are intact. It's not as common, but it can occur. So in ruptured membranes, the bacteria starts in the vagina or the anus or the rectum, and it moves up into the uterus, infecting the chorion and the amnion. When women have intact membranes or their water has not broken yet, the bacteria can travel up through the genitourinary tract. And this can cause infections to both mom and baby, and severe infections. Clinical manifestations would look like a very, very high temperature, maternal and fetal tachycardia, because remember it's affecting both our mom and our baby, a uterus that is tender to the touch and often painful, a discharge from the vagina that has a very unusual but significant smell to it. In most cases, this may mean that the fetus has to be delivered as soon as possible because it's in an environment that is full of infection. The amniotic fluid, the uterus, the chorion, the amnion, everything has an infection in it now, and the baby needs to be delivered. The next thing we're going to talk about is substance abuse. So we screen all our moms for this. Risks when you are using substances can be preterm labor, premature, prolonged rupture of membranes, intrauterine growth restriction, placental abnormalities, and we have to monitor our babies for withdrawal symptoms. So opioid epidemic, which we all know has been going on for a few years, very high in the state of Ohio, is a newborn crisis. There is a spike in opioid-addicted babies born in the U.S. that has tripled in the span of 4 years. NAS stands for neonatal abstinence syndrome. So this is what's happening when these babies have to withdraw from the opioids used by mom in pregnancy. NAS can result in babies having these following symptoms. And I will tell you from personal experience taking care of babies like this, they often have almost all of these. Irritability, low birth weight, poor feeding, seizures, microcephaly, decreased motor development, diminished cognitive skills, severe diarrhea that leads to really bad skin breakdown, dehydration, continuous high-pitched crying or almost sounds like a screaming, and excessive sneezing, as that's a reflex that's kind of gone haywire. Preterm labor is also another risk factor or another high-risk antepartum consideration. And this is when it happens after 20 weeks, but before 37 weeks. So in order to be considered a preterm delivery, and remember, think back to your G's and your T-PALs that we talked about, it has to be between that 20 and 37 completed weeks. A major cause of death, and it has a major impact on already high cost of medical care. The average baby that stays in the NICU for any good length of time can run close to $1 million. So it is a high cost of medical care to keep preterm infants alive because every aspect of their body has been affected by being preterm, and they require multiple specialists, multiple doctors, multiple surgeries, multiple medication in order to just continue to try to live. Lung maturity is the main concern, however. Moms can get something called betamethasone, which is a steroid that helps increase the production of surfactant. So we talked earlier how surfactant has to be present in the infant in order for them to have alveoli that can expand and take on gas exchange. So if a baby is born before surfactant is made or it's fully made, they can have issues with lung immaturity. So there is a steroid that we can give mom, and it's called betamethasone. It's an IM injection that needs to be given twice, 24 hours apart, and it can temporarily help speed up the production of surfactant. So this is often given to our moms who are at risk of delivering prematurely or are inevitably going to deliver prematurely. Like she's in the hospital, we're banking on the fact that she's going to deliver this baby early. We're going to go ahead and give her this betamethasone to start trying to increase that production of surfactant. Early prenatal care can greatly reduce your risk factor of delivering preterm. A lot of preterm labor has to do with poor nutrition, not identifying underlying health conditions. It can be due to medications that you take or that you haven't taken your prenatal vitamins. So if you have good prenatal care, you can reduce the risk factor of delivering early. Now, not everyone. Preterm labor is one of those things that they don't understand fully. They don't understand why some people deliver preterm and some don't. They don't have 100% reason why some women with no pre-existing conditions who have a healthy pregnancy and a healthy diet still deliver preterm. So there's still a lot of research that goes into that. Risk factors can be, though, a prior history of a preterm delivery, an incompetent cervix, which we talked about earlier, where that may require a cerclage, Multiple fetuses, meaning if you have twins or triplets, you're more likely to deliver early as the uterus runs out of room and starts to contract. You can have polyhydramnios or oligohydramnios. Both of those conditions can cause you to deliver early. An infection like that chorioamnionitis may cause you to deliver early. PROM, which is premature rupture of membranes. You can have, so your water breaks before you're in labor. Chronic health problems like diabetes mellitus, hypertension, clotting disorders. Smoking, alcohol, or substance abuse can put you at higher risk for this. And patients who are younger than 17 or older than 35 have an increased risk if there's inadequate nutrition or obesity. Signs and symptoms of preterm labor would obviously be contractions or cramping, feeling sick, pain in the vulva or the thighs. Sometimes the cramping is more abdominal, like diarrhea, a low or constant backache, or feeling like the fetus is balling up. There is a test we can do, and that's called a fetal fibronectin test. And a positive FFT is when a protein from the fetus, which leaks into the vaginal secretions, if infection is occurring, which causes uterine activity or effacement to occur. So if this protein is identified, then we know that you're at increased risk of delivering early. Treatment can be putting mom on bed rest, preferably in that left lateral position, giving her oral fluids to prevent dehydration, treating an infection if that is the indeed cause of the preterm labor, giving tocolytic therapy to stop the uterine contractions. Now remember, we talked magnesium sulfate is a smooth muscle relaxer. The uterus is a smooth muscle. So not only do we use magnesium sulfate as an anticonvulsant in that preeclampsia we talked about earlier, but it also can be used in the prevention of preterm contractions as it smooths and relaxes the muscle of the uterus. We can also use drugs like terbutaline or ridodrine. We can use prostaglandin synthesis inhibitors like indomethacin, and we can use calcium channel blockers like nifedipine. Preterm labor medications, again, like I said, the magnesium sulfate, we can give this by IV infusion and then continue with PO once the contractions have stopped. We still need to look for signs of magnesium toxicity, as that's going to occur with this as well. And again, the antidote here is the calcium gluconate. The baby can have respiratory depression if born during magnesium therapy. So we have to keep in mind that they may require a little bit of resuscitation if mom has been being treated with magnesium sulfate during her labor. We want to monitor mom's vital signs, especially her pulse and her fetal heart rate and the respirations. In preterm labor medications like terbutaline, that can be given subcutaneously and that helps stop the contractions. The side effect, though, is an increased pulse in mom as well as blood pressure. So we have to look for signs of tachycardia with mom. With the ritridine, we can give that IV. With prostaglandin synthesis inhibitors like indomethacin or what we call indocin, we can give that orally and rectally, but it can reduce the amniotic fluid and the amount that is made. So we have to watch for signs of oligohydramnios. We cannot give this for long periods of time, and we may have to discontinue use if we notice that the amniotic fluid levels are not at ideal levels. And then calcium channel blockers like Procardia, we can give that orally, and a side effect of this can be hypotension. Preterm labor risk for mom and fetus. So again, if mom has an infection like chorioamnionitis and increases the rates of cesarean birth, and for the fetus, if the baby has infection, it can obviously, preterm labor can put the baby at risk for being born preterm, so preterm delivery. It can put the baby at risk for hypoxia or fetal deformities if the baby is born earlier than it has had time to fully form. When we talk about mom's membranes or her bag of water, we're talking about different ones. So we're talking about prolonged or premature preterm rupture of membranes, which is the rupture of membranes prior to 37 weeks. She can have PROM, which is the rupture of membranes before the onset of labor, but after 37 weeks. She can have prolonged rupture of membranes, which is membranes that have been ruptured for over 24 hours. And she can have previable rupture of membranes, which occurs before 24 weeks. That's the end of our high-risk antepartum slides.